Hello, this is Dr. Nolan. I hope you're having a good day. Today's discussion is going to be covering Chapter 14, which is on renal diseases and coexisting problems. What we're going to do is we're going to go over a clinical assessment of renal function. Then we're going to discuss further into acute renal failure and insufficiency, chronic renal failure, the management of patients with chronic renal failure, a little bit of discussion on renal transplantation, and some of the primary diseases of the kidney. Prior to getting ready into the kidney, you really have to basically have a clinical assessment value of renal function. We do this as we've discussed before in pathophysiology as your glomerular filtration rate. We usually can assess this using BUN and specifically serum creatinine and creatinine clearance. The good thing nowadays is that if you work in most more modern hospitals, the creatinine clearance is now being included in most of your tests. These are estimated values taken directly from serum creatinine and beyond ratios that are calculated via computer. The renal function and integrity is very important for the actual assessment of how much creatinine clearance is taking place. That's another thing that we're going to keep talking about. Remember the GFR normal should be around 90 milliliters per minute per 1.73 meters squared. It's the best estimate of true renal filtration function. If you have a clinical uremia, that means that your GFR is below 15 milliliters per minute per 1.73 meters squared. That has significant effects in the sense of not filtering waste products and it begins to accumulate in the patient. GFR can also be calculated and using this equation. I don't expect you to memorize the equation. It's rather to show you that these values are readily available for you. These are GFR calculations. You can put these into your equations into your iPad or iPhone or calculator, and so these can actually be useful if you have your serum creatinine levels, and you can use this equation very quickly to actually know what your GFR is. Your BUN is made up of many factors besides just filtration. It also has to do with the way the breakdown products of blood, urea, and nitrogen is taking place in the body, specifically the amount of protein load via dietary intake, the way the actual small bowel is actually processing it, as well as the gut flora health in the large bowel. If you get over accumulation of these products, the liver has to break them down as essential amino acids and eventually forms urea, and that urea pool can actually increase in certain disease processes, specifically if you don't have adequate renal excretion. BUN can actually increase due to several reasons. One is to a drop in GFR. It could also be from an increase in nitrogen and protein diet. It could be also from a patient hemorrhaging into their GI tract, where then they get accumulation of blood and products inside their bowel, and as a consequence absorb a greater amount of urea. You can also have increased catabolism, a total decrease in intravascular fluid volume, and other forms of disease states that you may see it. Remember, the normal value should be anywhere between 10 to 20 milligrams per deciliter. Anybody that has greater than 50 milligrams per deciliter, it definitely indicates a decrease in GFR. One of the things that you want to look at is you can look at the creatinine ratios to BUN. If you see a high protein intake, you will see the creatinine levels tend to stay normal or slightly elevated, but the BUN rises rapidly. In GI bleeding, again, you get an elevation in BUN, but no change in creatinine. In catabolic states, such as high fever, steroids, and burn patients, you get an elevation in BUN, but you don't see a change in creatinine clearance. Rhabdo, you also get a BUN rise, but you get a more significant effect in increasing creatinine because rhabdo is actually a breakdown of muscle, so you expect creatinine to also be released in high amounts in that situation as well. If you have patients with decreased substrates such as malnutrition or starvation, you'll see the BUN fall with creatinine not changing. If you have hypoperfusion, where you have significant dehydration, BUN will actually rise in comparison to creatinine, which will stay steady. Things like also congestive heart failure, shock, or diminished GI blood volume, such as GI bleeding, will also have elevations in BUN with no change in creatinine. If you have a urinary tract obstruction, as long as it's you have one kidney, you'll still have an elevation in BUN, but creatinine will stay steady. It's only when you get both ureters that are obstructed that you get a rise in BUN and creatinine together. Creatine, which is found in the muscle, it's a word, it's a Greek word for meat. Okay, the protein is produced from molecules such as L-arginine, glycine, and L-methionine. It's produced by the liver and the kidney. Creatine is then transported and taken up as a high-energy tissue, such as brain and muscle, skeletal muscle, and it acts basically as an energy sink and helps convert to ATP. Okay, so you have the creatine is basically helping transfer ATP from the mitochondria into the myofibrils, and basically making this system much more efficient. Creatinine, is a breakdown product of creatine phosphate. Remember, creatine phosphate is broken down by the liver. Remember, creatine phosphate is delivered into the bloodstream by muscle metabolism, and then it's converted by the liver into form creatinine, which forms at a fairly steady state, and then the kidney then excretes it in the urine. Creatinine is then cleared by the kidney and freely filters. There's really no reabsorption, and it has mild secretion, so it's higher than the actual filtration value. The normal values for most individuals, for females, is between 0.6 to 1 milligram per deciliter, and males is a little higher because they have increased muscle mass, around 0.8 to 1.3 milligrams per deciliter. Remember that this number varies. Individuals, if somebody is very muscular and a female like a muscle builder, you will see them have a higher creatinine as well. Creatinine usually varies with GFR, and increases in creatinine with no decreases in GFR could be simply due to an increase in muscle mass, increase in presence of chromogens in the blood, increase in creatinine production, and decreased tubular excretion in creatinine. Changes usually lag behind the GFR by about 7 days, so creatinine clearance is the most reliable estimator of a GFR, and the best way to do that is getting a 24-hour urine sample, which normally will give you 110 to 150 milliliters per minute. If you look at GFR and creatinine clearance, for every doubling of your creatinine, it indicates that you have a loss of GFR by about 50%. So every doubling effect, you get a 50% decrement in GFR. Decreases in creatinine clearance, once you get down to 10 to 25 milliliters per minute, has increased risk for prolonged or adverse responses to drugs that are excreted by the kidney. Typical example of these are things like non-depolarizing drugs such as aminosteroidals, vecuronium and pancuronium. They will have very prolonged effects with renal dysfunction. So renal tubular function can also be established by looking at urine concentrating ability. This can be done fairly simply by you looking at the urine specific gravity. This basically measures density of the urine. Normal values is that the urine is a little bit denser than normal water, being around 1.003 to 1.30. Remember, specific gravity is the density of liquid over the density of water. So urine normally is denser than water. And increases things that increase specific gravity, which means that you have more dense urine, which you have more waste products in the urine. You'll see from dehydration or things like overspillage of compounds like glucose, so glycosuria. If you see, on the other hand, a more dilute urine, which just decreases your specific gravity, it's never less than 1 because, of course, it can't be water coming out of you. Or things like diuretics, hypokalemia, and hypercalcemia can all lead to decreases in specific gravity. Urine concentrating abilities are also measured by urine osmolality. This is a measurement of urine concentration. It's a more exact measurement than specific gravity, and the normal value is anywhere between 38 to 1400 milliosmoles per liter. It depends on how concentrating the urine is. Greater than normal measurements may indicate things like Addison's disease, congestive heart failure, dehydration, spillage of glucose and glycosuria, renal artery stenosis, shock, and symptoms of inappropriate ADH. Lower than normal measurements may indicate aldosteronism, diabetes insipidus, excessive fluid intake, kidney failure, renal tubular necrosis, and severe pyelonephritis. Renal tubular function is indicated by the proteinuria as well. It's fairly common in about 5 to 10% of adults, but these tend to be transient and many times due to shock states that may be seen, like congestive heart failure. It may also be from increased breakdowns such as seizures, fever, patients that develop pancreatitis and have overexercised. Patients also sometimes will develop proteinuria, which is called orthostatic, which is seen in adolescents as well as in adults. It may be benign, these kind of situations. And then you may have persistent proteinuria, which is indicative of significant renal disease. If severe, it actually will lead to eventual hypoalbuminemia, and that actually begins to impact your anesthetic by decreasing the protein binding of the drugs. The other thing that you can measure for renal tubular function is urine sodium excretion. You're looking at the proximal tubules, important for remember about 65% reabsorption of sodium. The normal value should be less than 40 milliequivalents per liter. Your body really doesn't want to lose sodium. It's trying to maintain it. If you're seeing it less than 15 milliequivalents per liter, it may be indicative of hypovolemia. If you're seeing greater than 40 milliequivalents per liter of urine sodium, it may be due to increased sodium loss, and usually this is from hypoxic damage of the proximal tubular cells. It could also be due to simple diuretic therapy. The other things that you may actually indicate also renal tubular function is by measuring certain kinds of enzymes that are being spilled into the urine. Specifically things like NAG, which is an N-acetyl beta glucosaminidase. This is a lysosomal enzyme which is released by destruction of proximal tubular cells. It's pretty much indicative of hypoxic cellular damage of the kidney. The other thing that you can pick up is by looking at the alpha glutathione S transferase, which is 5% of the soluble protein in proximal cells. It also indicates proximal tubular damage. These are the kind of enzymes that are spilled with exposure to volatile anesthetics such as sevoflurane, which would indicate proximal tubular dysfunction. But you don't see an increase in BUN and creatinine, which is still worrisome considering that the only way you're picking it up is by you actually looking at the actual enzymatic spillage, which indicates damage. Of course, we've talked about this before, so I'm going to go over this kind of lightly. As remember, urinalysis gives you a tremendous amount of information, including content of the urine, such as protein, glucose, acetoacetate, blood, leukocytes, pH, solute concentration, sedimentic microscopy, including casts and cells, microorganisms, and crystals. So all these things are very helpful. As you can see in this picture, this is a cast of red blood cells, which would indicate that the damage of the hemorrhaging that's taking place in this individual's urine must be taking place inside the tubules. This is more of a nephro-induced disease. Okay, so let's start talking about different disease processes that you're going to see. The first one we're going to talk about is acute renal failure. And basically it's a deterioration of renal function that you can see over hours or days. This is usually diagnosed by seeing changes such as an increase in creatinine by as little as 0.5 milligrams per deciliter above baseline. So in other words, if you're going from a creatinine of 1 going to a creatinine of 1.5, that patient's undergoing acute renal failure. You may also have this diagnosis set by looking at a 50% decrease in creatinine clearance, and you see decreased renal function leads to the need possibly for dialysis. The kinds of acute renal failure that you have is oliguric, which is basically a description of urine outflow, which is usually still urine output of less than 400 cc's per day, to non-oliguric, where you see urine output is sometimes greater than 400 cc's per day. The associated with major increases in mortality by dialysis is that these people develop an increase of 50% mortality with acute renal failure. The incidence is around 5 to 7% of hospitalized patients, and it's really the highest incidence is in diabetic elderly patients or elderly patients with a degree of baseline renal insufficiency that's already present. Risk factors are degenerative processes from pre-existing renal disease, so you always want to make sure that you look at your baseline renal insufficiency and you try to protect those individuals as much as you can so you don't get them into acute renal failure, so you don't have that increase in morbidity and mortality. Remember, the degenerative process also get worse as patients age. Things that also make the acute renal failure more prevalent are things like low perfusion states, like patients with congestive heart failure. People with advanced coronary artery disease may also be more at risk. Patients that are undergoing sepsis, or multi-organ system dysfunction, or severe forms of dehydration. If the patients are exposed to certain nephrotoxic agents, you want to sort of avoid them, are things like non-steroidal anti-inflammatory agents. Patients receive very often in the operating room radio contrast, dyes, and patients with diabetes and renal insufficiency have a much higher incidence of going into full-blown acute renal failure of around 50%. In addition, if you add aminoglycosides to their overall management, as well as ACE inhibitors or even general anesthesia, may actually have nephrotoxicity effects. Diabetes, of course, is a risk factor in developing acute renal failure. Acute renal failure can be broken down into the three main components, either pre-renal, intrinsic renal, and post-renal. Pre-renal is basically anything that causes any kind of disruption in blood flow prior to arriving to the kidney. So this could be from things like renal artery stenosis, or simply from patients with low cardiac output states, or cross-clamping the aorta. All these can be causes of pre-renal syndromes. If you look at intrinsic renal disease, this is actual direct damage to the kidneys by inflammation, toxins, drugs, infection, or reduced blood supply causing poxy-retuberant damage, or even other forms of nephronic damage. If you're looking at post-renal symptoms, these are patients that have obstruction to the urine flow, where you get back pressure development and causing inability to filter due to this back pressure take place, and the kidney begins to fail as a consequence. Things like urinary obstructions from stones, masses or tumors that are obstructing, or things like prostate cancer, where the bladder becomes obstructed and leading to hydronephrosis and dilation and ineffectiveness of kidney filtration. In pre-renal patients, you see 50% of patients actually the hospital that are acquired acute renal failure are pre-renal. So this is one of the problems that we have to always think about pretty much in the highest priority. Sustained pre-renal acute renal failure leads to ischemic induced acute tubular necrosis. Things that will cause these acute pre-renal syndromes are things that are from hypovolemic shock, such as hemorrhage, GI blood loss, fluid loss, burns, and dehydration. As for relative hypovolemia, low perfusion states can also induce this, such as cardiogenic, neurogenic shock, or renal artery stenosis. Characteristics of urinary indices of patients with acute oliguria due to pre-renal or renal causes. If you look at the pre-renal causes, their urine sodium concentration is very low, at less than 20 milligrams per liter. Their fractional excretion of sodium is also retained at less than 1. The urine osmolarity is elevated at greater than 400. Urine creatinine to plasma creatinine is usually 40, which is indicating you a pre-renal syndrome, and then you have a urine to plasma osmolarity of greater than 1.5. If you actually have a renal cause, then the kidney begins to lose the ability to hold sodium, so it begins to spill. The urine sodium concentrations usually exceeding 40 milliequivalents per liter. You also get an increased fractional excretion of sodium that are greater than 1, and the urine osmolarity begins to drop down as water begins to follow where the salt is, and as a consequence, the osmolarity actually begins to diminish. The urine creatinine to plasma creatinine ratio is usually less than 20, and your urine plasma osmolarity ratio is less than 1.1. Now, if you look at intrinsic renal diseases, things like glomerular diseases, like acute glomerulonephritis, accounts for about 5%. Most acute renal failure due to intrinsic renal disease is ATN related, which is acute tubular necrosis, the actual renal tubules, which is usually the proximal tubules. Most of it is associated with ischemic events, but another fairly high percentage of these 85% of causes is due to nephrotoxic agents, which are around 35% of the whole of all these. These are caused by things like solvents, aminoglycosides, radiographic contrast dye, and things like microbinuria. The other 10% of the actual intrinsic renal disease can be from interstitial nephritis, which is still fairly rare. If again you look at the indices for these kinds of patients, it's really indicating to you that the kidney is losing the ability to retain sodium, and you see the increases in renal sodium excretion as a consequence to this effect. Pathophysiology of acute renal failure looks at ischemia or nephrotoxins. They end up causing release of inflammatory mediators. These inflammatory mediators do two things. They cause vascular and endothelial cell injury, as well as cause a tubular epithelial cell injury, including necrosis and apoptosis. With the necrosis of these proximal tubular cells, it causes cast formation, which eventually leads to obstruction and leads to reduction in GFR. If you cause tubular back leakage to also take place because the cells don't really hold tightly properly. The other thing that the vascular endothelial cell injury will cause is vasoconstriction and vascular congestion, which causes a persistent medullary hypoxia. And also it leads to a decreased glomerular filtration pressure, and eventually leads to overall to a reduction in GFR and oliguria. So acute tubular necrosis and obstructive uropathy, you get is two things that will happen. You see an increase in interluminal pressure as the obstruction from debris and necrotic cells begins to fill up the tubular lumen. This causes a back leak due to injured tubular cells having the inability to really protect the basement membrane, and allows this urine to be reabsorbed into the person, and it has an ability to filter out and remove toxins from the patient's body. The other cause of acute renal failure is the third cause, which is post-renal. This is usually from ureteral obstructions such as calculi, tumors, and other iatrogenic causes, such as a Foley catheter that's put in inappropriately and it bends and kinks and now it's obstructed the bladder. Things like bladder outlet obstructions from like prostate cancers or prostatitis can also have significant problems, and urethral injuries as well. Complications overall of acute renal failure is that the patient will develop symptoms of toxicity due to an inability to remove waste products out of their system, and as a consequence to develop a uremic encephalopathy. Cardiovascular-wise, the patient will develop an increase in preload because the person is unable to clear fluids. They sometimes will get excessive afterload, again due to either hormonal changes or due to excessive volumes. You see decreased contractility, again from toxins that are being built up in the heart, and you get ischemic, not so much ischemic problems, but more of a contractility loss due to this. You also can get significant heart rate and arrhythmias that may occur from electrolyte disturbances. As for GI-wise, the patient usually suffers from anorexia, nausea, vomiting, and may also increase the incidence of GI bleeding, and there's also increased incidence of infection in these individuals. Treatment of acute renal failure is to treat the possible etiologies, in other words, remove any toxins, or treat, if you know which one it is, if it's pre-renal, post-renal, or intrinsic renal, identify the deastrural disease process, then identify what's causing it, and then try to reverse the effects. Sometimes you'll need to consider invasive monitoring just to basically differentiate between preload, intrinsic, or post-renal diseases. You want to maintain adequate perfusion to the kidney around 65 mean arterial pressure. You want to consider giving these people fluid challenges. HESPAN, unfortunately, has to be very carefully given, less than 1 liter total volume, because if you give that, it may actually induce renal failure in patients. Crystalloids may actually be better, especially isotonic solutions are maybe better than 0.9% or normal saline. Hydration with isotonic sodium bicarbonate solutions and hypotonic solutions increase risk of D5 half normal saline. If you want to avoid nephrotoxic medications such as radiocontrast dyes, so consider using low-volume non-ionic isoosmolar dyes, or consider treatment with N-acetyl cysteine, which is a thiocontaining antioxidant, to not have the significant renal effects from these medications. Medications that you may also consider or not consider is diuretics should be avoided in pre-renal syndromes, but in loop diuretics in critically ill patients may have an increased mortality risk. It's been found. So if you used to put patients on a Lasix strip, it may not be actually a wise idea. I'm not really happy with why looking over these studies because the studies don't really differentiate if the reason for their LASIK difficulties was the degree of severity of the individual, and so I just don't really feel that they came up with a completely valid conclusion, but it's put in the book, so it's something to consider. The other thing that's bad about the high dose lidocaine, the high dose LASIX over a long time period of time is that it causes ototoxicity in many individuals with significant hearing loss that's persistent. If, on the other hand, if you decide to give mannitol, it's not usually indicated in prerenal syndromes. It says that that's inadequate flow to the kidney, so mannitol may not be the body's choice in that situation. It's indicated in some post-transplant patients because mannitol acts as an antioxidant removal and may actually help clear out these antioxidants. It's indicated also in rhabdomyolysis, and is indicated also for dilute toxins in nephrons. Medications that may actually help are things like inotropes that increase cardiac output. Does not appear to be affecting the outcomes. So are these drugs really indicated? The question is, most of the time, most of the reports are saying no at this time. So dopamine really hasn't been found to be all that effective in helping in these individuals. Renal dose dopamine may do more harm than actually good, and studies conclusively state there is basically no benefit to it. Norepinephrine, actually, if you give it appropriately and you don't make the patient metabolically acidotic as a consequence, in other words, you're vasoconstricting them too hard, actually seems to decrease incidence of acute renal failure in individuals. So when appropriately dosed, seems to be very beneficial. Phenoldipan, which is a selective dopamine 1 receptor agonist, has been found to increase your renal blood flow and increase your GFR. It significantly reduces the incidence of acute renal failure, but does not prevent contrast nephropathy, and its risk is it caused hypotension in a lot of individuals. Phenoldipan is actually one of the newer agents that we have that may actually make a difference in actually maintaining kidney function in people. And acetylcysteine has a decreased incidence of contrast nephropathy as well. Drug dosing with renal impairment. First of all, you want to establish your GFR. If the patient's oliguric, then use 5 milliliters per minute GFR. If you look at unloading dose, the extracellular volume is normal, then you do a normal loading dose. If you think that the extracellular volume is reduced, then you decrease your loading dose. If you're looking at your extracellular volume is increased, then you need to increase your loading dose in these individuals. You may want to have to change your increase in interval time on the plasma half-life depending on how the drug is actually metabolized and then removed. These are the kind of things that I sort of think are important. If you look at this individual that has a low GFR, you can see that some drugs actually have to be increased in their dosing interval. So like things like acetaminophen, normally you would at normal GFRs you would see a Q4 hour treatment. By the time you get down to less than 10 milliliters per minute of GFR, you have to avoid acetaminophen completely, or increase it to a minimal of 8 hours dosing. Things like our narcotics don't really have to be adjusted. It seems like they maintain most of the time, except for things like codeine and fentanyl. You have to reduce it by 50%. Your dosing interval. Toradol, I would recommend you don't use for any renal impairment, and most of the time. That's why the little star is for, because it may actually induce renal failure in some individuals. Patients that are receiving methadone also have a decrease widening a time interval if their GFR rate drops significantly. Chronic renal failure is the next disease process we'll talk about. It's a progressive, irreversible deterioration of renal function. Diabetes is the leading cause of end-stage renal disease, and hypertension is the second leading cause of end-stage renal disease. What you see is a GFR of less than 25 milliliters per minute, which eventually leads to end-stage renal disease. the increased incidence of end-stage renal disease is due to the increasing age of our population. Causes of chronic renal disease is very much associated with things like glomerulopathies. These are primary. You don't have to memorize these, but I think you do have to know some of the secondary ones, such as diabetes, post-streptococcal glomerulonephritis, and lupus and Wegener's may also cause chronic renal failure. You may also have tubular-interstitial problems, hereditary diseases, hypertension, renal vascular disease, obstructive uropathy, and HIV may all lead to basically chronic renal failure. Treatments to decrease the progression include reduced systemic glomerular hypertension, such as ACE inhibitors or angiotensin receptor blockers. Things that a reduction in proteinuria may also be helpful by using those agents as above. Dietary low protein. It's really unclear in humans. In animals, they've been shown to help, but in humans, it's really unclear. If you restrict lipid and dietary phosphate, there's really been no change in chronic renal failure development. On the other hand, if hyperglycemia can be avoided, it really helps decrease the incidence of end-stage renal disease. And since diabetes is one of the highest risks for developing chronic renal failure, it shows you that tight control is very important in these individuals. Things that we also know is that growth factors such as cell proliferation that increases cell proliferation and fibrogenesis can be partially inhibited by ACE inhibitors. The physiologic effects of chronic renal failure, the early signs is you develop what's called uremic syndrome, where the patient develops anorexia, nausea, vomiting, anemia, fatigue. They get itching, they develop coagulopathy over time, and the BUN is a useful indicator, but not creatinine, and treatment includes protein restriction in these individuals. Late signs eventually are fluid overload, electrolyte disturbances, with significant acid-base disturbances going towards metabolic acidosis. Congestive heart failure is common due to dramatic increases in preload. Ischemic heart disease, cognitive impairment due to inability to remove toxins in the bloodstream, peripheral neuropathy, and increased susceptibility to infections as well. The electrolyte imbalances of chronic renal failure, things like hyperkalemia will develop late. Things that can actually trigger acute events such as hyperkalemia will be things like acidosis, patients who develop hemolysis, sepsis, hyperglycemia, or oliguria. If you start seeing EKG changes, basically treatment is considered urgent. Things like peak T waves, prolonged QRS, an elevation in PR interval, and complete heart block and BFib may actually ensue. So in these kind of patients, you've got to treat them by dialysis as rapidly as possible, or any other way you can to decrease potassium levels, such as giving administration of Kxalate till the patient develops diarrhea. The way you treat these hyperkalemic events is you want to discontinue any kind of exogenous potassium. You want to try to membrane stabilize and increase the arrhythmogenic threshold. This can usually be done by giving the person calcium chloride, which is a preferred choice instead of calcium gluconate, because calcium chloride is actually 3 times more elemental calcium than gluconate, and it's not really used to lower potassium levels, but rather to try to stabilize the membranes to prevent arrhythmogenic potential. What you're seeing here is a typical example of what happens with hyperkalemia. In a hyperkalemic patient, the actual potassium gradient is poisoned, and you are able to maintain the patient now in a depolarized state that's above the threshold, so the patient cannot fire the cell, and the patient goes into asystole in that situation. If you look at the actual cardiac muscle cells, the muscle cells also poison there, and it goes into a depolarized state where the muscle cell cannot fire as well. So you have the pacemaker cells and the muscle cells both losing their ability to cause any kind of electrical potential. As a consequence, the person develops asystole. Hyperkalemia treatment is to shift the potassium intracellular, where the potassium is very happy, and usually most people have 150 milliequivalents per liter of potassium in their cells. This can be done by simple interventions such as hyperventilation. Sodium bicarbonate can also is controversial for acidosis, but has been proven beneficial for hyperkalemic arrest. Glucose and insulin is also using the pump to help drive potassium into the cell. And things like beta agonists such as albuterol also have been important in driving potassium back into the cell. Elimination of potassium is also possible with agents such as kyaxylate, which I described before is given a PO until the patient begins to have diarrhea. These are binding agents that will bind to potassium inside the GI tract. You can also administer Lasix, such as a potassium-wasting diuretic, and ultimately dialysis may be the treatment of choice in some of these individuals. The other thing that's very common in electrolyte imbalances in chronic renal failure are things like hypermagnesemia, hypocalcemia, and hyperphosphatemia. They may also develop significant metabolic acidosis when you have low GFRs. You have an inability to excrete the acids that are being produced, which leads to chronic acidosis, which is a problem. This leads to oftentimes lethargy, fatigue, respiratory alkalosis is evident to try to compensate for it. You see catecholamine resistance because the proteins are becoming denatured, so epinephrine, if you administer these individuals, may not be effective like you expect. You also may see protein catabolism that's taking place from severe prolonged metabolic acidosis or denaturing. You may see worsening renal osteodystrophy and decreased protein binding of calcium. Renal osteodystrophy is from low GFRs, which leads to a decrease in phosphorus clearance and an elevation in plasma phosphorus and to overall decrease ionized calcium levels. This leads to an elevation in parathyroid hormone secretion, which then leads to bone resorption and increases the risk of developing pathological fractures. There's also decreased renal production of vitamin D with decreased GI absorption of calcium, elevation in parathyroid hormone secretion, and bone resorption. And renal osteodystrophy also leads to an increase in serum alkaline phosphatase, and sometimes we'll get aluminum, what's called bone disease, which is good that we're avoiding more aluminum nowadays, and that's going to cause also pathological fractures. Parathyroid hormone and calcium homeostasis is important for the kidney. The kidney is controlled reabsorption of calcium by parathyroid hormone, as well as a degree of reabsorption of the bone. Physiologic effects is that anemia leads to a decrease in erythropoietin. This excess parathyroid hormone increases fibers to replacement of bone marrow. Treat with erythropoietin these individuals because they're not producing it adequately. This hopefully prevents blood transfusions and increases the renal transplant rejection rate if you have to give people multiple blood transfusions, and it worsens the hypertension. Aplastic anemia after parathyroidectomy may also develop in these kind of individuals. Coagulopathy is actually fairly common in chronic renal failure, and it's usually due to uremia that's never been cleared properly by the kidney. This can be seen in effects like GI bleeding, epistaxis, hemorrhagic pericarditis, subdural hematomas. You can also get normal labs at bleeding time, and you treat these patients with cryoprecipitate. The other thing to consider is for these uremic kind of bleeding is to give the person DDAVP, also known as desmopressin. It's an analog of the antidiuretic hormone, which increases levels of von Willebrand's factor and increases activity of platelet activity to von Willebrand's factor. And the max effect usually is 2 to 4 hours duration to 6 to 8 hours. And it's attenuated by repeated doses, so you shouldn't be giving that if you can avoid it. And the other thing you can also consider giving is giving conjugate estrogens, which can last up to 2 weeks to help reverse some of the uremic bleeding symptoms that you see. Neurological changes that occur due to chronic renal failure are things like mental status changes. Patients become more irritable. They develop insomnia. They have decreased deep tendon reflexes, obtundation. Encephalopathy may follow up with coma, and they may have distal symmetrical polyneuropathy and partial improvement with hemodialysis from these individuals.